Hello everyone, I'm Dr. Swarna and I'm a postgraduate in oral medicine and radiology. The topic of the talk today is benign and malignant tumors of oral cavity. Being working in this department for last 5 years, I have a special interest in this topic, and I think the only mantra to deal with this particular the branch or all these lesions is to have an early diagnosis followed by a correct treatment. So let's begin with it. So moving forward, we begin with what is neoplasia basically, or what are tumor. So they are abnormal mass of tissue, the growth of which exceed and is uncoordinated as compared to that of normal tissue, and it persists in the same excessive manner even after cessation of the factor or the stimuli which has evoked that change. Now, if we see at the classification, so they are broadly classified into non-odontogenic and odontogenic tumors. Non-odontogenic tumors, the one which we'll be discussing in today's lecture will be epithelial tissue origin and connective tissue origin. The other tissue of origin tumor, they are discussed as separate topic by different speakers. We'll also be discussing the odontogenic tumors, both benign and malignant. So beginning with the benign tumors of epithelial origin. The first one in this is squamous papilloma. Remember one thing, whichever lesion you are reading, you should go about in a sequence, read in that sequence, write your answers in that sequence. That makes a great difference. That makes your answer great. So what's that sequence? Always think of why that lesion is named so. One thing. Then next is to think about what is the etiopathogenesis of that lesion. Once you know the etiopathogenesis, go towards the epidemiology of that lesion. That what is its distribution, the age, the population it's affecting. All right. Then once that is done, next thing that you do is you should go for the clinical features of that lesion. Post clinical feature, the radiographical features, then the pathological features. When all those features are being covered, we should look for the differentials clinically, histologically, and radiologically. When differentials are done, the last thing that we should study is investigation, that how to go about in that lesion investigation and the treatment associated. All right, so if we look at this particular lesion, that is squamous papilloma. So why it's termed as squamous papilloma? Because if we look at the histological picture of this lesion, there will be finger-like projection, that is papilloma, which are lined by stratified squamous epithelium. So this appearance gives it a name squamous papilloma. Now we look at its etiopathogenesis. So it has a strong relation with HPV, that is human papilloma virus 6 and 11. Unlike other human papilloma virus induced pathology, this is non-contagious, right? And this occur in 1 in every 250%, and age most typically involved, predicted is 30 and 50, between 30 and 50 years. However, sometimes children below 10 years of age are also affected. There's no discernible gender predisposition and a modest male predominance is seen. You can see in this picture the finger-like projection lined by stratified squamous. Now, if you look at the clinical picture, so there will be an exophytic pedunculated painless growth. The areas most commonly involved are, सबसे पहले is lip and palate, followed by tongue, buccal mucosa, gingiva. In the palate, the area most commonly involved is adjacent to uvula. This lesion has a strong association with the syndrome, Cowden syndrome. Cowden syndrome is nothing but a combination of multiple hematomas in GI tract, mucocutaneous lesions, facial papules, and acral keratosis. Traditionally, this lesion has been divided into two types: isolated and solitary, and multiple recurring. So the oral cavity ones are the isolated solitary ones, while the multiple recurring are found in laryngotracheobronchial complex. Couple of days back, I came across a very interesting case of squamous papilloma, which happened on a rare site that was in the mandible when I saw its CT scan. So, the destructive involvement of this remus portion was seen, and if we looked at its coronal field or coronal section, so the left ascending branch of jaw with soft tissue mass, its destruction was appreciated. If we look at the histological features, other than that finger-like projection lined by stratified squamous, we also saw spinous cells proliferating and coilocyte HPV altered cells were there. Now, what are coilocytes? Often being asked in vivas. So it is nothing but when the upper layer epithelial cell have or demonstrate a nuclei that are pycnoted and crenated, and they are surrounded by a edematous or optically clear zone. We call them as coilocytic cell. Presence of them is indicative of a virally altered state. So now what are the differentials? Clinically, it has got four differential: condyloma acuminatum, vericiform xanthoma, vericiform carcinoma, and papillary inflammatory hyperplasia. Now, I have mentioned the differences, that how to differentiate. So, condyloma acuminatum will have a broad base and pink red color, while in squamous papilloma, white and less broader base will be there. Vericiform xanthoma, the site predilection is different. They have gingiva and village. Then carcinoma, of course, there will be different histological properties. Then papillary inflammatory hyperplasia, name itself suggests that they'll have chronic injury as its etiological factor. Now, if we look at the treatments, so the conventionally what we go through is the excision of the base of the mucosa into which pedicle insert. Other than that, curettage, liquid nitrogen, cryotherapy, and tropical cherolytic agents such as salicylic acid and lactic acids can be used. All right. So the next topic of the talk is keratoacanthoma. It's a second benign epithelial lesion, and it is a self-healing carcinoma, and also known as molluscum sebaceum because of its origin from the pilosebaceous glands. So now, as I told, whenever you are beginning to read about a topic, always think that why it is named so. So keratoacanthoma, why it's named so. So acanthosis happens in this lesion along with the keratosis. So now what is acanthosis? So acanthosis is the thickening of the spinous layers of the epithelium, and keratinization happens. So it could be ortho or parakeratinization. Now, it's a low grade malignancy, as discussed earlier, with the origin in the pilosebaceous gland, and it is considered to be a variant of invasive SCC. Looking at its etiological factors, it includes sunlight, trauma, HPV, and chemical carcinogens. And it is seen more commonly in immunocompromised patients and genetically susceptible ones. And it happens more commonly in fair skinned people and in sun exposed areas. Because of its more prevalence in the sun exposed area, it is less likely to occur inside the oral cavity. The common age of occurrences increases as the age increases, and there is a male predilection with 2:1 ratio. So the most common site of involvement is face, neck, and dorsum of the upper extremities. It can be at times seen on lips because of the exposure to the sunlight, while intraoral lesions are very uncommon. If you look at the clinical picture of this lesion, what you see is that there are elevated, umbilicated, or cratiform area with depressed central core or plug. It is often painful, and regional lymphadenopathy may be present in these lesions. Further, If you look at the histological picture, in the low power view, what you can see is, yes. So in the low power, you can see that there is apparent invasion of the lamina propria in one of the fragment borders. Along with that, in the high power, if you see the microscopy details, there is moderate infiltrate of the inflammatory cells. Then what you can see the keratin plugs present. And other than that, but you can see that there is occasional mitosis seen in these areas. And what else? There will be mild cellular pleuromorphism in the basal cell region, yeah, basal layer. All right, moving forward. So if we look forward, if we look at the differentials of this lesion, it includes squamous cell carcinoma. As very in the beginning, I said that it's considered to be the invasive variant of the invasive SCC. Then it has a close differential with amelanotic melanoma and molluscum contagiosum. Treatment include surgical excision, and the other proposed treatments such as cryotherapy, electrodesiccation, irradiation, then using of 5-fluorouracil, curettage, X-ray, radium implantation, electrocautery, silver nitrate cautery, hydrocortisone, and antibiotic ointment and podophyllin as a supplementary or additional helpful agents, along with the main line of treatment, that is surgical excision. Okay, so the next topic of discussion is oral nevi. These are also known as oral melanocytic nevus, nevocellular nevus, or simply mole. Now, these are hematomas. What are hematomas? The benign proliferations of nevus cell happening either in the epithelium or connective tissue. They can be congenital, that is right from the birth, or acquired. Histologically, they have been divided into intradermal, junctional, or the mucosal variant. And most common clinical variant is intramucosal nevus, followed by the blue nevus. If you look at the clinical picture, usually it occurs in white patient over the age of 40 years, mostly females, and the most common site of predilection is hard palate and buccal mucosa. They are asymptomatic, pigmented, brown, black, or blue colored, well circumscribed, raised lesions. Sometimes they may be amelanotic, means there will be absence of melanin. Sessile growths, which resemble which lesion? Fibromas or papillomas. And compound nevus involving the mucosal epithelium and connective tissue. Right? Okay. So if you look at the histological picture, you can appreciate this as your nevus cells are present only on the junctional epithelium in the basement membrane. So it is junctional nevus. When that reaches towards the deep connective tissue, it becomes compound. Now, when the connection with the basement membrane of the epithelium is lost, it is either intradermal or intramucosal. Now, in the blue nevus, what happens? There'll be elongated melanocytes with long dendrites. So, this is the histological picture of the different variants of the oral nevi. If we look at the differentials, so it is melanotic macule, melanoplakia, and amalgam tattoos. It has a strong association with PK mole syndrome. Now, this is a rare autosomal dominant syndrome, and the syndrome include multiple melanocytic nevi, family history of melanomas, increased risk of pancreatic cancer and other malignancies. There is one special variant of oral nevi, that's white sponge nevus, wherein we see white patches that appear as thickened velvety sponge-like tissue, and the most common site of occurrence is buccal mucosa. The commonest treatment modality for it includes surgical excision that we carry out in the daily clinical procedures. And the most common variant, which have a greater risk for malignant transformation, is the congenital one. Cured ones are less likely to go through that. All right. So continuing further. So here we comes to the malignant tumors of epithelial origin. The first one in the sequence is basal cell carcinoma, also known as rodent ulcer. So why rodent ulcer? Because of the local destructive natures of the rodents, which is similar to this lesion, they are known as rodent ulcer. So it's a slow growing, rarely metastasizing, and has the ability to have a significant local destruction. Most frequently develops on exposed surfaces of the skin, face, and scalp in the middle-aged or elderly fair-skinned people. And it is thought to rise from pluripotent stem cells of the basal cell layer as well as the follicular structures. If we look at the etiology of this disorder, again, it has similar as we discussed in the case of keratoacanthoma. Here also, sun-exposed areas more commonly involved. Radiation like X-ray, chemicals like arsenic, immunosuppression, and syndromes like xeroderma pigmentosum and nevoid BCC syndrome. If we look at the clinical picture, so clinically, most frequently, they are seen in the fourth decade of life, and they have a male predilection of 2:1, double that of the females, and it is most frequently seen on the middle third of the face, and it does not arise from the oral mucosa. Rather, it is a invasion from the adjacent skin surface towards the intraoral site. The subtypes of PCC include nodular, pigmented, cystic, superficial, and morphiform. So, nodular PCC, it is most common variety, and it begins as a slightly elevated papule with central depression, which ulcerates, heals over, and then break down again. Very mild trauma may cause bleeding. Eventually, the crusting ulcers, which appear superficial, develop a smooth rolled border, which is a characteristic of any malignant ulcer, representing tumor cells spreading laterally beneath the skin. The pigmented one will have black or brown pigmentation in addition to the features we saw in the nodular BCC. Cystic BCC may what you'll see, there'll be translucent blue-gray cystic nodule that may mimic benign cystic lesions. The superficial variant will have scaly patches or papules, commonly on the trunk region. Micronodules may, what we'll see, it's an aggressive variety, very less prone to ulceration, and will have seemingly very defined borders. The last variant is the morphiform or infiltrating BCC. So it's the most aggressive one with scar-like plaque or papule, which may be mistaken for scar tissue. Border is usually not well defined and often extends well beyond the clinical margins. Ulceration will be seen, bleeding and crusting, very common in this variant. You can look at the picture. There'll be elevated areas, crustation is there, ulceration is there. So this is the picture, seemingly at times avoided, but it's a dangerous one. Treatment will have, if it's a small lesion, less than 1 centimeter, surgical excision, laser ablation, or electrodissection and curettage, with 5 margin of normal appearance skin taken out. Large lesions, radical surgery, or radiotherapy is the solution. For sclerosing type or recurrent lesion, most micrographic surgery are used. Prognosis is usually good as it doesn't metastasize and recurrence is very, very rare. All right. So the next epithelial origin malignant lesion is squamous cell carcinoma. Whenever we refer to oral cancer, unless it's specified, it is nothing but squamous cell carcinoma. It's a malignant neoplasm of squamous differentiation, so it is termed so, and is characterized by formation of keratin pearls or presence of the intracellular bridges. The most common malignant neoplasm of oral cavity is SCC. Further, if we look at the etiology of this lesion, so tobacco is in its various forms, especially when coupled with excessive alcohol, is a very important etiological factor. And other than that, UV radiation, pre-malignant lesion and condition like leukoplakia, erythroplakia, poor oral hygiene, vitamin A and C deficiency, immunosuppression, and rare conditions like xeroderma pigmentosum. Along with that, there is also strong association with HPV infection. Besides all the causes, tobacco and UV radiation is only established causes of SCC. All other causes are supposed to have a synergistic effect on the former two causes. If we look at the clinical feature, and so the male predominance is seen with 2:1 ratio, mainly found in elderly after fourth decade of life. The site most commonly involved is vermilion bottle of the lower lip, tongue, floor of the mouth, palate, gingiva, buccal mucosa, in this descending order. So the most common one is vermilion border of the lower lip. If we look at the mortality rate, it is lowest for the lip cancer and highest for the tongue region. Clinically, two very characteristic features of this lesion are ulceration and an indurated margin, hardened margin. Any swelling, papule, discoloration that show abrupt screen increase in the size, with change in the surface texture, with surface ulceration, change in the surface color, or any non-healing chronic ulcer, they all are indicative of SCC. Very prime chief characteristics one should look for whenever in clinic. So in this case, another thing that we come across is that there is regional lymph node enlargement and tenderness, which is simulating the metastatic tumor. And along with that, patient come with complaint of pain and difficulty in mastication. So clinical signs of oral cancers has been divided into early and late signs. So early signs include persistent red or white patch, which is not giving response to any of the usual used medical agents. Then if there is a non-healing ulcer, if there is a progressive swelling or enlargement, which is unusually rapid, unusual surface changes, sudden tooth mobility without apparent cause, unusual oral bleeding or epistaxis, or prolonged hoarseness of the voice. In the later stages, what we see, there will be an indurated area, a hard, stony, hard area. Paresthesia, dysthesia of tongue or lips, airway obstruction, chronic ear ache, right? Then trismus and dysphagia. Cervical lymphadenopathy can be seen in the later stage. Persistent pain or referred pain, altered vision epiphora can also be seen. If we talk specifically about the SCCs of a particular location, say we are starting with the carcinoma of lips. So this region is going to be involved mainly in the elderly men. It usually begin on the vermilion border of the lip to the one side of the midline. Often how it starts with small area of thickening, then induration, ulceration or irregularity of the surface. Later on, it may create a small crater-like defect or produce a proliferative growth. Either ways it can go, but beginning there will be thickening, induration or ulceration. Generally, it is slow to metastasis, but when it does, it's usually ipsilateral. What it involves, which nodes mainly lips area में कौन सी involve होंगी? Submental or the submandibular nodes. Contralateral metastasis may occur only in the condition if the lesion is occurring close to the midline or crosses the midline. What is the treatment protocol in this region? Surgical excision with or without radiation, and prognosis is good in this region. If we look at the carcinomas of the tongue, here a relationship with syphilis has been strongly suggested through various studies. If we look at the clinical features in this in the side on the side, so the most common surface of the tongue that is involved is lateral border and the ventral surface. So how it presents? It presents as a painless mass or ulcer, which might become painful if it is secondarily affected. It may begin as a superficially indurated ulcer with slight raised border, which is a characteristic of the carcinomatous ulcer, and may develop into later on into a fungating exophytic mass, or it may infiltrate the deeper layers of the tongue, producing fixation and induration. Lesion, if occurring on the posterior portion of the tongue, has higher chance of malignancy. What treatment protocol we use? So surgical excision with radiation, and this area is most has the poorest prognosis and difficult to treat. Next region is floor of the mouth. So here how the lesion will present: as an indurated ulcer of varying size situated on one side of the midline, more frequently in the anterior portion of the floor. Sometimes it may produce limitation of the motion of the tongue because of the tongue attachment in the same region. So there will be limitation. A limitation of motion of the tongue may cause slurring of the speech. These lesions most commonly occur near the midline, so they have a higher chances of contralateral metastasis because of the presence of the lymphatic cross drainage presence. And in this region, the best way of treatment is using radiation, better than the surgery. Smaller lesions have higher chances of recurrence in this region, while the larger ones do not do such. And this region has a very fair prognosis. Next site which is involved is buccal mucosa, and it has a very strong predilection of occurrence in men, almost 10 times more than females. And if we look at the etiology, so there is habitual quit of chewing tobacco for years. And if we look at the clinical features in this one particular site, so it is seen along or inferior to the line opposite to the plane of the occlusion, less frequently on the line above the plane of the occlusion. Lesion is often painful ulcerative one where induration and infiltration of deeper tissues is common. At times the lesion may be exophytic, but more chances of the ulcerative lesions seen on the buccal mucosa. Metastasis is very frequent, and here the treatment we use is combined uses of surgery or the X-ray radiations. Now the next site is gingiva. Now which gingiva is most commonly involved? It is mandibular ones. Initially, how the lesion will look, there will be ulcer, which may be purely erosive, or at times it may have an exophytic growth, usually arise. In which area exophytic growth will arise? In the edentulous areas. Which layer of the gingiva most commonly is attached gingiva is more commonly involved than the free gingiva. And along with that, we can see erosion of the underlying bone, and metastasis is more common in the mandibular gingiva. Treatment is generally difficult and is followed by a bad prognosis. Next region where we can see SCCs are palate, but it's not a very common site. And if we look at the clinical feature, how it appears. So it's a poorly defined ulcerated painful lesion on one side of the midline, frequently crosses midline and may extend laterally to include the lingual gingiva, or posteriorly to involve the tonsillar pillars or even the uvula. It may invade the bone or occasionally the nasal cavity while infiltrating lesion of soft palate, and may extend into the nasopharynx. Metastases occur quite commonly in this region, and prognosis is again not very good in the palatal region. So we use a combination therapy of surgery and radiation. If we look at the differentials of this disorder, so deep fungal infection like histoplasmosis, bacterial infection like tuberculosis, and traumatic ulcers. So these are very frequently being considered to be the differentials of SCC. This disorder, this lesion, has been graded based on the TNM grading of SCC. And how to go about it? So this TNM staging has three elements. T is the primary tumor, mainly talks about the size of the tumor and gives a number, T1, T2, T3. And then N is the nodal involvement, whether there is nodal metastasis or not. And last is distant metastasis. M is distant metastasis. So M0 and M1. So this you can find in any of the standard textbook. Based on these numbering, the staging of the disease has been done. So for T1, M1, M0, it is stage 1. The moment the size is greater than 2 but less than 4, that is T2, it is stage 2. Then post that, from T3, without regional lymph node involvement and distant metastasis, is stage 3. And T1 or T2 of with N and M will belong to stage 3. For stage 4, there will be T3 along with N1, T4, N0, or N1, M0. Any T with N2 or N3, M0. Any T, any N, any and M1. These all dictates for stage 4. So coming to the treatment portion of this disorder, the first line of action is surgery. Surgery could be excisional surgery, cryosurgery, curettage and electrosurgery, laser surgery. Second modality is chemotherapy using the medicines, then radiation therapy, which may be tele or brachytherapy. As a thumb rule, stage 1 and 2 are treated by surgery with or without radiotherapy. Stage 3 by radiotherapy and surgery with or without chemotherapy. And 4, we only provide supportive care. Talking about the radiation dose that we use, it is somewhere between 50 and 70 Gauss, and usually given over a 5 to 7 week period, once a day, 5 days a week. And if we talk about the radioactive elements which are used in the radiation dose, then it is 192 iridium, 137 cesium, 125 iodine, and 198 gold. Drugs that we used in the chemotherapy after radiotherapy, the chemotherapy, small detail, the drugs that we use are bleomycin, cisplatin, methotrexate, and 5-fluorouracil. Okay, coming to the next lesion after SCC, it's verrucous carcinoma. It's a warty, high-grade variant of SCC. It's predominantly exophytic overgrowth of well-differentiated keratinizing epithelium having minimal atypia, local destructive margin. Now, why it is called verrucous? Because of its appearance similar to the cauliflower. If we look at its age of occurrence, it's usually in elderlies in an age average between 60 to 70 years, most commonly on buccal mucosa and gingiva. In the clinical feature, you can very well see that there is pebbly papillary appearance, usually covered by a white leukoplakic film, and the lesion on the gingiva may grow into soft tissue and invade and destroy the underlying bone. Regional lymph nodes are enlarged and tender, simulating the metastatic tumor. And here again, pain and difficulty in mastication will be a common complaint. Patient would come to you, and growth is usually slow and metastasis occur late, if at all. It may become more aggressive if it is irradiated, so that has to be done. Differential of this disorder include verrucous leukoplakia, papilloma, and verrucous hyperplasia. In the treatment, conservative excision is done. Risk of anaplastic transformation is very likely if irradiated. So this is a very important red flag when dealing with verrucous carcinomas. Next malignant lesion is malignant melanoma. So basically, it is a neoplasm of epidermal melanocytes. One of the most biologically unpredictable, and deadly of all the human neoplasias. It is the third most common cancer of skin after BCC and SCC. Previously, it was believed to be developed from junctional nevus, which is pre-malignant melanocytic dysplasia of some kind, and it can arise de novo or from any pre-malignant melanocytic dysplasia. If we look at its etiology, so its etiological factors have been divided broadly into environmental factors and genetic factors. In the environmental factor, the most common factor is sun exposure. The UV sources, artificial UV sources could also be the one. Socioeconomic status, fair skin, red hair, and the number of melanocytic nevi present. In the genetic factors, familial melanoma and xeroderma pigmentosum accounts for these genetic factors. Risk factor of oral melanomas are unknown. Most of these are thought to arise de novo. And they have two great growth phases that we see in malignant melanoma, radial growth phase and vertical growth phase. So cutaneous melanomas can be classified into four. Superficial spreading, that is, they are showing the radial growth phase. Nodular melanoma, lentigo malignant melanoma, and acral lentiginous melanoma. Now, talking to the area of our interest, that is the oral manifestation of malignant melanoma. So they are twice as common in men than in women. Again, that is 2:1 gender distribution. And most cases occur between 40 to 70 years of age. Site most commonly involved is palate, gingiva, maxillary gingiva. And usually how it appears, melanin involvement, if it is there, so deeply pigmented area, at times ulcerated and hemorrhagic, which tends to increase progressively in size. So oral melanomas exist in superficial spreading, acral lentiginous, and nodular types. Now there is a very important ABCDE rule in clinical diagnosis of malignant melanoma. Very commonly asked question in vivas. So what it is? These are the 5 key factors for the clinical diagnosis of this lesion. So what is A? A is asymmetry of the lesion, right? Then B is the border irregularity, that the border will be blurred, notched, ragged edges. Okay? Then C stands for the color irregularity. Pigmentation is not uniform, black, brown, red, tin. So they'll be all will be appearing together and there'll be color irregularity. Then D stands for the diameter will be greater than 6 mm. Growth in itself is a sign of this. And E is the elevation. You can very well appreciate here all the 5 factors in this picture. If you look at the differentials, so blue nevus is a very strong differential of it. Then traumatic hematoma and hemangioma. Now, how to treat these lesions? So, surgical excision for oral melanomas, jaw resection, and lymph node dissection. Women have a much better survival rate up to 50 years, and then the rate declines as compared to men. Nodular and superficial spreading melanomas have poor prognosis than as compared to the lentigo type. And oral melanomas have a much poorer prognosis than the cutaneous ones. Coming to the next section of our discussion or say talk. So we are done with benign and malignant tumors of the epithelial origin. Now we'll go forward further on the benign tumors of the connective tissue origin. All right, moving forward. But before we move forward, very basic difference often being asked in the vivas and often being not answered. What is difference between benign and malignant tumors? So, benign tumors are expected to have a slow growth, while malignant are expected to have a very rapid growth. Benign are usually encapsulated lesions, and rare, while in the malignant, the encapsulation is rare to see. Benign will grow to expansion, but there will not be infiltration in the surrounding tissues, while in the malignant tumors, there will be infiltration seen. Benign are less likely to recur after surgical removal, while the malignant are very prone to show the recurrence. Other than the other difference, that there will be minimal tissue destruction when it comes to benign lesion, while there is immense infiltration and tissue destruction in the case of the malignant tumor. So these are few basic differences between benign and malignant tumor. So this, whenever it's asked, it has to be answered. All right, moving forward. So in the connective tissue origin, the first tumor that is to be discussed is fibroma. So fibroma is also known as irritational fibroma. So what it suggests, that it is a reaction to a chronic irritation or trauma. It's a most common benign soft tissue neoplasm of oral cavity. If we look at the epidemiology, so there's a female predilection of 2:1, and the most common site of occurrence is buccal mucosa along the plane of occlusion. Here we can see well-defined slow-growing lesion, and the age of occurrence is third, fourth, and fifth decade. If we look at its clinical picture, so there would be elevated nodule of normal color with smooth surface. It may be sessile or pedunculated. That means it may be without stuck at the base or maybe with stuck. Treatment for it is surgical excision, simple. Next, benign connective tissue lesion is giant cell fibroma. So here, it is asymptomatic sessile or pedunculated nodule. Usually, it is less than 1 centimeter in size with papillary surface. You can appreciate in the picture. The most common region which is involved is mandibular gingiva, twice as much as that of the maxillary gingiva. Other common sites are tongue and palate, and the treatment of this is simple, again, surgical excision, fair prognosis, and rare recurrence. Next, benign tumor is peripheral ossifying fibroma. So this is also known as peripheral calcifying fibroblastic granuloma. It's a reactive rather than neoplastic in nature. And some peripheral ossifying fibroma are thought to develop initially as a pyogenic granuloma, in which the fibrous maturation happens, then calcification happens, and eventually they form POFs. It occurs most commonly where? On the gingiva, in the maxillary arch, in the incisor cuspid region. Remember, any sort of growth seen in this region is most likely to be POF. So it's going to be seen as a nodular mass, either again pediculated or sessile, both ways. Then usually arise from interdental papilla, see over here in this picture, and it can be red to pink, and frequently ulcerated surface are seen in this mass. In the treatment, the first step is to remove that irritant which was causing the problem, and local surgical excision is done. Prognosis is good, less recurrence chances are there, and one thing we must remember, that the mass should be excised down to periosteum so that the recurrence remains low. The next lesion is central ossifying fibroma. Now this is neoplasm of bone with remarkable similarities with central cementifying fibroma. And the age is third to fifth decade of life, and female predilection is seen. It is typically asymptomatic. What it shows then? Displacement of the teeth. Radiographically, there's a well-defined unilocular lesion with sclerotic border, and depending upon the calcification, completely it could be radiolucent or maybe too radiopaque. So based on the calcification, its radiographic appearance vary, and conservative surgical excision is the treatment. Now, since both POF and COF have very similar, feature, so what does that differentiate them? So POF are classified under benign connective tissue lesions and may arise due to inflammation, while COF are under FO, fibroosseous lesions, and represent an osteogenic tumor. Most common place of occurrence of POF is gingiva, while CUF occur in long bones but rare in skull and jaw bones. And never confuse that POF are not the soft tissue counterpart of CUF. They are distinct entities, right? And POF are not further classified, while COF are further classified as sematoid and juvenile type. Next lesion is pyogenic granuloma. So it's a misnomer. Why it's a misnomer? Because there is no feature of granuloma seen in this lesion. It's a non-neoplastic, painless nodular growth arising from interdental papilla, especially in the anterior region of the maxilla. It's most commonly seen in females. Why? Because of the reason of its more female predilection has been linked to the high amount of the female sex hormones. And that is the reason it aggravates in pregnancy and thus termed as pregnancy tumor. Then the causes, if we look at the causes, so it is gingiva's hyperresponsiveness to local trauma and irritation. So if we look clinically, the area which is most commonly involved is the interdental area, interdental papilla, more than lingual papilla. And maxilla is more commonly involved in mandible, anterior regions more than posterior region. And now how is the appearance? So it could be red to the purple, smooth like this, or maybe lobulated, pedunculated or sessile, nodular lesion with increased vascularity and usually ulcerated surface ranging from few to centimeters. Soft to palpation and mature lesions are firm to touch and reduced bleeding tendency. In the treatment, when the moment we remove the local irritating factor, they regress on their own. While some long-standing fibroid cases can be treated with conservative surgical excision. All right, so the next lesion is peripheral giant cell granuloma. It's a relatively common tumor, like growth of oral cavity, and it is a reactionary lesion to the local irritation or trauma happening, like any denture is causing some irritation, a chronic infection, or tooth extraction. If we look at the epidemiology of this lesion, so it happens in fifth and sixth decade of life, and with the female predilection, site of involvement is mostly mandible, more than the maxilla, and anterior and the posterior region. These occur exclusively on gingiva or edentulous alveolar ridge, presenting as red or reddish blue nodular mass. It can be pedunculated or sessile with or without surface ulceration, mostly less than 2 centimeters in size. So you can see the reddish appearance of it, and it could be sessile or pedunculated. And for this, treatment is local surgical excision till the underlying bone, along with the removal of the source of the irritation. Then the next lesion is central giant cell granuloma. So this is also known as giant cell tumor. It's a non-neoplastic but aggressive lesion which mimics neoplasm. And it has female predilection, and the site is mandible more than maxilla. And it is mostly in the anterior region and frequently crosses midline. It's asymptomatic, however, may be associated with pain, paresthesia, or perforation of the cortical bone plate. Radiographically, we see unilocular or multilocular radiolucent lesion, well delineated but non-corticated. So this is a clinical picture. This is how the CG, that is central giant cell granuloma, you can appreciate. And over here in this picture, and here you can see that in the radiograph, so there is multilocular appearance can be appreciated. Now, since PGCL and CGCL Both are very closely sharing many common features. So we need to know the differences of them. So PGCL is a reactionary lesion to the local irritant factor, while CGCL etiology is uncertain. PGCL is non-neoplastic. CGCL is also non-neoplastic. While PGCL is an extraosseous lesion, gingiva and alveolar ridge are the area of involvement, while CGCL is intraosseous. If we look at the clinical behavior, CGCL is way more aggressive and it has a higher recurrence potential. Histology is similar in both of them. Origin of giant cell is again uncertain, but since CGCL is very aggressive, so the growth is very rapid. One very important difference that CGCL will show endophytic growth, while PGCL will show exophytic growth. Bone resorption is naturally present in a more aggressive lesion, while it's rare when it comes to uh, little aggressive lesion. Dental root resorption is rare with PGCL, and in case of treatment, PGCL, the only treatment is surgical, while CGCL, surgical along with pharmacological modalities can be taken off. So the next benign lesion of connective tissue origin is hemangioma. And one very important peculiar characteristic of such lesions is that they undergo distinctive phases of, proliferation and involution. So, and this is present at birth and later on it regresses. So this is the distinctive phases of its growth. In oral cavity, hemangiomas are not that very common, but head and neck is most common site. According to Watson and McCarthy, it has been divided into following types. So the most common one are the first two, capillary and cavernous hemangioma. Rest others are also found, but mostly we come across these two cases. Then there are a list of syndromes which are associated with hemangiomas. So namely ones are Randu-Oster syndrome, Sturge-Weber syndrome, Kasabach-Barrett syndrome, Maffucci syndrome, von Hippel-Lindau syndrome, and Klippel-Trenaunay-Weber syndrome. So these are very important from the point of view of viva, from the point of view of, entrance examinations. So now coming to the clinical features, the clinical characteristics that we come across in hemangioma, beginning with the age of occurrence. So it is mostly in infants or children. So basically it occurs at the time of the childhood and it progresses and then regresses. So it is commonly occurring in infants or children. It usually affects whites but rarely occur in black, and it has a very strong female predilection with a ratio of 3:1. If we look at the most common site involved, it's lip, tongue, buccal mucosa, and palate. Now, the area where it's most commonly seen, the facial bone which is most commonly affected is mandible, followed by maxilla, followed by nasal bones. Then intramuscular hemangiomas are seen in oral region, and the most commonly involved muscle is masseter. If we look the clinical characteristics of the lesion, so they'll be either flat or raised, deep red or bluish red lesion, rarely well circumscribed. They readily are compressible and fill slowly when relieved. So this is a property seen in hemangioma. So there's a compressibility seen, and 2/3 of the central hemangiomas were located in mandible, and they are bone destructive lesion, often resembling cyst and cause root resorption. But the difference from cystic lesion here, we can find that the vitality of the tooth is not affected. If we look at the treatment, how to go about. So they have found to be themselves undergoing spontaneous regression at a relatively early age. Cases which do not show such remission, so they should be treated by surgery, radiotherapy, cryotherapy, or sclerosing agents like sodium mauryate or silicate can also be injected to the lesion for good result. Prognosis is excellent, and Rarely or maybe never they turn to malignancy or have any recurrence. The next lesion is lymphangioma. So these are benign as well as they are hematomatous hyperplasia of which region of the lymphatic vessels, and the 3/4 of all the cases of head and neck region. Now, Watson and McCarthy have also classified lymphangioma, namely simple, cavernous, cellular, diffuse, and cystic lymphangioma. And if we look at the clinical picture of these lymphangioma, so intraoral form most commonly occurs on tongue, and superficial lesion are manifested as papillary growth, papillary region, same to the color of the surrounding or slightly on a redder side. While the deeper lesion appear as a diffuse nodular masses without any significant change in surface texture or color. The irregular nodularity of the surface of the tongue with gray and pink projection and when associated with macroglossia is a pathognomic of lymphangioma. Remember this. These characteristics are a very strong depictors of lymphangioma. Now, whenever lymphangioma involves lip, we call that condition as macrocelia. An unusual form of lymphangioma occurs in alveolar ridge in neonates, which exhibit small blue dome fluid-filled lesion on the alveolar ridges of the black newborns. Now you can see how the intraoral lesions we are seeing and how this asymmetrical growth in a child. These all are except a few good cases of lymphangioma. Now we look at the treatment. So surgical excision is a treatment of choice since it is radioresistant and sclerosing agents are of no use in this case. Spontaneous regression is rare, which unlike hemangioma, and because of the non-encapsulated and infiltrating nature of lymphangioma, complete removal is often impossible without excessive removal of surrounding normal structures. So this was about the non-odontogenic tumors. We discussed two tissues, that was epithelial and connective tissue. As I told earlier, rest of the tissues will be taken in the separate lecture sections. So beginning with the odontogenic tumors, they have been classified broadly into benign and malignant. In the benign, we have, based on their origin, they will be originating from odontogenic epithelium without odontogenic ectomesenchyme. So the common ones include ameloblastoma, squamous odontogenic tumor, calcifying epithelial odontogenic tumor, and edetomatoid odontogenic tumor. The second class in the benign tumor is where the origin is from odontogenic epithelium with odontogenic ectomesenchyme with or without hard tissue formation. Third class is odontogenic ectomesenchyme with or without, including odontogenic epithelium, opposite of that we saw before. In the malignant, again, it is based on its tissue of origin. Either it is odontogenic carcinomas or odontogenic sarcomas. So beginning with the most common odontogenic benign tumor, that is ameloblastoma. So this term was coined by Churchill in 1934 to replace edementinoma, which was given by Melisses in 1884. Several definitions for ameloblastoma has been, proposed. The most accepted ones that we use, that we tend to write in examinations are, one is by WHO. So they state that ameloblastoma is a true neoplasm of enamel organ type tissue, which does not undergo differentiation to the point of enamel formation. While Robinson has defined it as tumor that is usually unicentric, non-functional, intermittent in growth, anatomical benign, and clinical persistent. So these 5 characteristics which Robinson has attributed to ameloblastoma: unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. Amongst all the odontogenic neoplasm, this is the second most common one. Now, what is origin of ameloblastoma? So, cell rest of enamel organs, either remnants of dental lamina or remnants of Herdwick sheath, epithelial rest of Melissae. So, these are the origin places. So, epithelium of odontogenic cyst, particularly the dentridgeous cyst and odontomas, they are again the source of ameloblastoma. Then, any disturbance of developing enamel organ, then basal cell of surface epithelium of jaw, and heterotrophic epithelium in other parts of the body, especially pituitary gland. Currently, it's been thought as a result of alteration or mutation in the genetic material of cell that were embryogenically pre-programmed for development is the reason. If we look at the genetical contributions, so overexpression of TNF alpha, anti-apoptotic proteins like BCL2, BCL-XL, and interface protein, that is fibroblast growth factor, matrix metalloproteinase. So these are the genetic predispositions. So ameloblastoma is further classified, or its variants include central, peripheral, and pituitary ameloblastoma. So central intraosseous is the central one. Most common, second most common odontogenic tumor. Now, peripheral ameloblastoma, that is an extra osseous variant. So it will be involving the soft tissues. Third is the pituitary ameloblastoma. So it is craniopharyngioma, Rathke's pouch tumor. Now, WHO has classified ameloblastoma into four: solid or the multicystic, extraosseous or peripheral, desmoplastic, and unicystic. Most common, which one we found is solid or multicystic. If we look at the clinical features of ameloblastoma, so the central type include 10 years through 90 years with peak at 33 to 39 years, only 10% in below 10 years. No significant sex predilection, and it occurs in all the areas of the jaw. However, mandible is the most common one. If we see the site most commonly involved, it is molar angle ramus area, greater than 3 times than the premolar and the anterior regions combined. As previously discussed in the WHO's classification, that it may be either solid or unicystic, but solid ones are more common one. Usually asymptomatic and are discovered either during routine radiographic examination because there is asymptomatic jaw expansion happening. See. So the first variant, that was the extraosseous ameloblastoma, it occurs in the soft tissue outside and overlying the alveolar bone. They originate from either surface epithelium or remnants of the dental lamina. Now, peripheral ameloblastoma has predilection for the males, and side predilection is in the mandible. It is found as nodules on gingiva, varied in size from 3 mm to 2 centimeter diameter. Very small, that is 3 mm to 2 centimeter. And it resembles basal cell carcinoma of the gingiva, and it is relatively onchoish, lacks persistent invasiveness, and it is very limited in its tendency to show recurrence. You can see the peripheral ameloblastoma. Third variant was pituitary ameloblastoma, so usually found in the supracell area, and it grows in a radial growth pattern. If we look at the radiographic feature, so it could be unilocular or multilocular, which usually smooth but in advanced lesions scalloping. Sclerotic margins can be seen. It exhibits a compartmented appearance with septa of bone extended into radiolucent tumor mass, which gives it a honeycomb or soap bubble appearance. Now you can appreciate in this radiograph the jaw expansion or thinning of the cortical plate. You can see that. If we look at histological point of view, there are 6 subtypes. which include follicular, acanthomatous, plexiform, granular cell, basal cell, and desmoplastic cells, desmoplastic type, sorry. And other features we found is that there will be disconnected island strands and cords within collagenized fibrous connective tissue stroma. And this ameloblastoma would consist of all columnar cells with hyperchromatic nuclei, reverse polarity of the nuclei, and subnuclear vacuole characteristic of palisating pattern. So, what is palisating pattern? It's like, second moment. So it's like a tile like of a pattern like this. So tiles are parallel. Similarly, that palisading pattern is seen. If we look at the treatment, so it includes both radical and conservative surgical excision, curettage, chemical, and electrocautery radiation. Mostly we go for the combination of surgery and radiation. Curettage is least desirable one, and radiation is not preferred because of its high radio resistance. When we are doing surgical excision, so what we do is safety margin of 1 mm is taken, and for the chemical cauterization, Kerner solution is the chemical treatment of choice. What is Kerner solution basically? So it is a combination of 60% ethanol, 30% chloroform, and 10% glacial acetic acid with 1 gram of ferric chloride. All right, so the next lesion is calcifying epithelial odontogenic tumor, which is also known as Penberg tumor. It's uncommon benign odontogenic tumor, which is exclusively epithelial in origin, and its locally aggressive tumor comprises 1% of all odontogenic tumor. And if you look at its histogenesis, so here, as suggested by Pinberg, stratum intermedium and strands of remnants of dental lamina are the origin of this tumor. And amyloid deposition are believed to be the immunological response to stratum intermedium cells. Now look at the clinical picture of this lesion. So before that, the epidemiology of this lesion is that it occurs in the age group from 8 to 92 year, with age predilection 4th to 6th decade, and no specific gender predilection is there. Mandible is affected twice more than maxilla, and the most common site involved is molar ramus angle region, thrice common than the premolar region. Now, if we look at the clinical features, so it is asymptomatic, expansile, hard bony swelling, may be associated with unerupted or impacted tooth. And the tumor show buccolingual extension with thinning of the cortical plate, and eggshell cracking effect is there. Tipping, you can see in this picture, tipping of the tooth and rotation or root resorption or mobility of tooth in the affected area are the common findings. If we look at the radiographical features, so it's a mixed radiolucent lesion, unilocular or multilocular, both ways radiolucency, which will have ill-defined margin and flecks of calcification. You can see here are seen, which gives a wind-driven snow appearance. Sometimes unerupted tooth is present inside the lesion, mimicking dentigerous cyst. If we look at the histology of this lesion, so there will be proliferation of polyhedral epithelial cells in islands, strands, cords, or sheath, which sometimes show cribiform appearance. Now, there would be homogeneous amyloid deposition among the cell, which gives it a Lesgang ring pattern. Very important. And in the polarized light, there'll be apple green birefringence will be seen. So to treat such lesion, excision or curettage is done if the lesion is larger or recurrent. So segmental resection is indicated. atypical COT or malignant COT, and they are radical resection, radiotherapy, chemotherapy, combination of three is being used. Here recurrence rate is 10 to 20%. Next is edematoid odontogenic tumor. So it's an uncommon tumor mostly associated with unerupted maxillary canine. Histogenesis is unknown. It is odontogenic because it arises in tooth area and histologically resembles cells of dental lavina. But exact histogenesis is unknown. If we look at its age, so it is 69% of the cases occur in second decade of life, and it has got a female predilection with gingival lesions more common in females, 14 is to 1, and over 30 years of age, females have lesser predilection as compared to males. Site most commonly involved is maxilla, and it is anterior to the canine. Two-third tumor is a name given to this tumor. Why? Because two-third of the tumors occur in maxilla, two-third in young patients, two-third in association of with unerupted teeth, and two-third of affected teeth are canines. So this is very important from point of view of Viva. Now, these lesions are asymptomatic bony swelling in maxillary anterior region, mostly resulting in facial asymmetry and most commonly missing canines or delayed eruption. When they occur in mandible, so very clear buccolingual extension is seen and it extends to a limit that the mandible fractures. Seals. If we look radiographically, so there'll be unilocular or multilocular radiolucency with some foci of calcification, smooth sclerotic or corticated border, and there'll be erosion of the cortical plate and displacement of the tooth. See. Treatment indicated is conservative surgical excision and recurrence is rare. The last lesion, odontogenic tumor, we'll be discussing is odontomas. So these are hematomas or malformation of dental tissue and not neoplasm. Similar to teeth, do not develop further once calcified, may erupt into the mouth, form during the period of odontogenesis, and can become carious if exposed to saliva. So they have similarities to the tooth. Both epithelium and mesenchymal cell exhibit complete differentiation, which results in functional ameloblast and odontoblast. If the organization of the odontogenic apparatus fail to reach the normal state of morphodifferentiation, such entities or lesions are seen. Now, this is classified into compound and complex odontomas. So, easy way to differentiate between them, the odontoma, which has similarity to tooth, are compound, which do not show any resemblance to tooth, are complex odontomas. If we look at the clinical features, so age 10 and 19 years, no sex predilection, site maxilla, anterior region of the maxilla, we find compound odontomas more commonly, while in the posterior, complex are more common. They present as hard, painless masses, usually accidentally recorded on routine radiographic examination. Rarely any patient comes with any complaint of pain. The problems associated with it are caries, as discussed earlier. If exposed to saliva, caries develop. Abscess formation, prevent eruption of the tooth, displace teeth, and cyst formation. Radiographic features, compound odontoma, many separate small denticles will be there, and they will be resembling the structure of normal teeth, and simpler gross morphology. In the complex, there will be dense opacity, radiolucent rimming will be there, developing within a dental follicle, and if infected, the calcified tissue may be mistaken for a sequestrum. So compound odontomas are treated enucleated surgically, and the complication post the treatment they have is dentigerous cyst, Gardner syndrome of intestinal polyposis, multiple odontomas, and odontoameloblastoma. Complex odontomas are also enucleated surgically. However, here complication that we come across are potential obstruction to eruption, focus of infection, and cosmetic lesions. This was about benign and malignant tumors. If any one of you interested in today's age, the age of artificial intelligence, and want to get inside of this topic from the point of view of artificial intelligence, so this is my book. It has got vast knowledge base of application of artificial intelligence in benign and malignant tumors. It's available on Amazon and different platforms. For any query regarding this topic, feel free to ask me, and this is my email address. I hope you people have enjoyed this topic and will read more and come back with more doubts. Thank you.